I want to start by thanking the Society as well as the moderators for inviting me to talk today. You can see my Twitter handle on the right side. Feel free to tweet furiously about how wonderful my talk is, either during or afterwards. I have nothing to disclose financially. I will say, though, my talk doesn't have any surgical videos. It's a rare situation that I'm talking about today, and I already forget to press play all the time for routine cases. The format's also new to me, so I'm afraid I'm going to make some mistakes. Specifically, I'm worried about cutting off the talk when I hit the next slide. Hopefully that doesn't detract too much from the content. Nightmares is a great idea for a symposium. I love it. To prepare for it, I went back and watched the old 1980s documentary, Nightmare on Elm Street, to refresh myself on some of the important teaching points from Professor Kruger. This is what I remember him saying back then. First of all, when you die in a dream, you die in real life. Very important. Freddy Krueger is fueled by fear, so you have to manage your fear in these situations. And lastly, 80s hairstyles really don't withstand the test of time. If you look at some of these dudes, they're pretty hilarious. I will say that this was Johnny Depp's first movie role, which is news to me. Now, I kept my hair pretty simple in the 1980s. That means that I didn't land any sweet small roles in horror movies, but I also don't have my poor choices immortalized on YouTube, so I feel like I may have won in that situation. A lot of people like to put quotes from famous pioneers in surgeries. This is one that I got from a very famous surgeon from the 1980s era. I apologize. This is a recorded talk. If I'm talking to a room full of people, I can tell when my jokes bomb and when they kill. Here, you just got to listen to me unopposed. But if you want to ignore the rest of the talk, just take a screenshot from your desktop of this slide, because this has got the 4 studies that I think tell the most about this topic and are very important. In order to frame this talk, we have to understand how often people get diverticulitis after having a sigmoid colectomy. This is probably the most famous study on the 1986 study from the Mayo Clinic. They had about a 10.4% rate of recurrence after sigmoidectomy, and 2.9% of their patients required surgery for recurrent diverticulitis. This is probably the most widely quoted talk, and I read about this when I was a resident and used the same numbers on my patients for years. Some of the newer studies have a little bit more favorable numbers. There's a Cleveland Clinic, Florida study from 2003, very well done. It reported a 5% rate of recurrence and about a 0.4% rate of reoperation. There's a study from the Netherlands I included for completion's sake with an 8.7% rate of recurrence, but this is a very heterogeneous study, and I would give the least amount of weight to this one. And then the most recent series, Albany Medical Center 2020, had a 4.2% rate of recurrence after sigmoidectomy, and 0.3% of their cohort required reoperations after sigmoidectomy, and they had a mean time to recurrence of 55 months, so these are relatively late recurrences. What are the predictors of recurrence? The main predictor is the level of the anastomosis. The worst thing you can do in this case is spare the distal sigmoid colon and perform a colocolonic anastomosis. The Mayo Clinic reported that 22.7% of people with colocolostomies had recurrence versus 6.2% of people with a colorectostomy. The numbers are a little bit better, but still pretty impressive for Cleveland Clinic, where they had a 4-fold increase in recurrence when you have a colocolonic anastomosis compared to a colo. Things that don't predict recurrence: staple versus handsewn, whether it's proximal colonic diverticula, mobilization of splenic flexure, or laparoscopic versus an open approach. What does that mean? That means this situation is uncommon. This should be less than 0.5% of sigmoid colectomies done for diverticulitis. And so if you're coming across these patients, it's quite possible there's residual sigmoid colon distal to the anastomosis, and this should factor into your decision making. When it comes to nightmares, the first step is trying to avoid the nightmare. I just want to bring this up. A lot of these are going to be referrals from the outside center, but when you're doing these cases, if I have to have one take-home point, is make sure you don't leave any residual sigmoid colon. I've seen a lot of videos on YouTube where you can see that they didn't quite get down to the rectum, and it's really not good. When it comes to preparing for war, you have to study the past. And so when it comes to these cases, the first step is to read the operative note in detail. Try to find out if they ligated the inferior mesenteric artery or not, if they took down the splenic flexure. Look at the anastomotic details. Step 2, you have to study the current anatomy. And the first step with that is meticulous review of the CT scan to look at the level of the anastomosis, relation to adjacent structures. And in my experience, a lot of these patients have hernias and they have mesh, and so you have to keep that in consideration as well. I also do my own colonoscopy. You also have to know your opponent. These are almost never emergencies. You have time on your hands to get all your ducks in a row. Nutritionally optimize the patient, make sure that they stop smoking, rehabilitate them best as you can, and additionally you have to manage your expectations. The patient going into surgery have to understand that they're at risk, or of having several things change in their life, including an ileostomy, an LAR syndrome, and hernias. It's important that you rehearse the case. This has been shown in literature to help outcomes. So for me, I'm always trying to anticipate intraoperative findings. Am I going to find the bladder's immobilized and it's more posterior than I expect? Adherence of adjacent structures. And I have an escalation plan in place to begin with. What is going to be my threshold to conversion to hand-assisted surgery or an open surgery? When am I going to call for help? And I don't want to be scrambling for a bunch of instruments when things are stressful, so I make sure I have all these things in the room before I get started. I also tend to expect the worst in these cases and hope for the best. So I have the patient marked and consented for possible loop ileostomy, and I always keep in mind that that is not a failure to give a loop ileostomy. It's good judgment in the right situation. I also put ureteral stents in every patient every time. The cool trick with the ICG is not going to help you if you've converted to open surgery. And I don't schedule it as the fourth case of the day. I don't schedule it with clinic afterwards. I expect that it's going to take longer than expected. I also have to have extra help on standby, which I think is kind of obvious. I also think the situation is not a good time to be fancy. These people are here because they had a bad first surgery most of the time. You can't unscrew somebody by rescrewing them. What that means is this shouldn't be your first ever Da Vinci SP case of transrectal extraction. You don't have to do them open, but you need to use a technique that you're familiar with and you've got some mileage practicing. Intraoperative steps. I tend to get in left upper quadrant, even if I don't plan to use that port for anything. I think 5s are free. Obviously, you're going to identify the critical structures up front. For me, it's the bladder and the ureter. Try to find virgin planes, and if you're lucky, and you'll find a lot of times when this is done at the outside facility, the presacral space has not been violated, and you still have a flexure to take down, and that's helpful. Mobilizing the phlegmon. Blunt dissection is actually very good for this, especially if you decide to use the hand-assisted approach. But remember that you can easily create false planes, so be very careful. It's very easy to poke a hole in a bladder in this situation. Be mindful of adjacent structures. They're usually a little more protected but more vulnerable because the planes have been violated. Specifically, things can be stuck down the presacral venous plexus, the ureters on the right side as well, and then obviously the bladder we talked about. Distal transection. Really, there's no specific technique of choice for this. I would just tell you that in general, you're going to find yourself lower in the pelvis than you expected on these types of cases, and you have to treat it like a pelvic case, including being careful not to damage the vagina and other deep structures when you're stapling. I tend to use an anterior posterior approach laparoscopically. I think I can get deeper in the pelvis with that. And then if you're open, sometimes a green load contour stapler is also a good option because this is a thick tissue that a blue load is not going to do the trick on. Getting enough length, this is very important for these lower anastomoses. You ligate the IMA, but most importantly, you have to ligate the inferior mesenteric vein at the ligament of Treitz. This is a very important move to get you several centimeters. And if you simply can't get it to go down, you can always do a counterclockwise rotation, known as the Deloyer's procedure. It works when you're in a pinch. You're going to get frustrated during these cases, no matter how hard you're trying, no matter how good of a surgeon you are. So you have to remember that no matter how hard the case is and how long it's taking, they all end the same way, which is that the colon is in a bucket and you're in the surgeon's lounge drinking coffee. So I tried to get this done in less than 10 minutes. So I talked fast. This is my second time trying to record it as well. I actually ended up being a little early, so we can take our time now. But what I'd say is, a summary: the surgery of recurrent diverticulitis after sigmoidectomy is rare, at least it should be. Study the past well when preparing these cases. Rehearse the case, plan for the worst. And remember that Freddy Krueger is fueled by fear, so you cannot be intimidated. Finally, just to get serious for a minute, this is a big case, and so you need to make sure that you get a good night's rest the night before the big case. If you dare. Alright, so thank you very much again for the time on the podium, the virtual podium today. I apologize if my jokes weren't good. Really, there's no way for you to give me feedback because this is a recording. So as far as I know, I'm killing it just as effectively as Freddy Krueger killed teenage girls in the 80s. Thank you.